Fungal and yeast infections of the skin are exceedingly common. The skin, the hair and the nails may be affected, and somewhere between 5% of the world population have, for example, a fungus infection of their nails. So they're important and common infections. The skin may be infected by true fungi, and these are called the Dermatophyte fungi, and there are 3 different genera: Microsporum species, Trichophyton species, and Epidermophyton species. And these are multicellular filamental organisms which produce fungal hyphae. They produce superficial, scaly eruptions on the skin. By contrast, yeasts are unicellular budding organisms, and the most common being Candida. Although most fungal and yeast infections are superficial, deep infections can occur by much rarer organisms, particularly in the immunocompromised. So as mentioned, dermatophytes may spread from human to human, and these are called anthropophilic dermatophytes. They may spread from animals to man, but then they don't spread from man to man, and these are called zoophilic fungi. And very occasionally we can get dermatophytes which come from soil, and these are called geophilic. And as mentioned before, species identification by culture will allow us to determine whether that particular fungus has been acquired from another human or an animal, and that animal species may be very specific. I think it's really important to take specimens before treatment for these very reasons. So how do I identify the presence of dermatophytes within the skin? Well, it's very easy in clinic to take skin scrapings, so these are pieces of scale which are put onto a glass slide. We then apply potassium hydroxide solution to the slide, warm it up, and then look at them 5 or 10 minutes later. And if we're lucky, we can see the hyphae that demonstrate the presence of a dermatophyte infection. We can also send scrapings off for culture on a special fungal medium called Saboreau's medium. Fungi grow slowly, so the results of those might take up to 2 to 3 weeks. Some species of a dermatophyte which affect the scalp will fluoresce, so we can look at these with the Wood's light as we saw for the identification of erythrasma. More recently, molecular diagnosis using PCR has come into mycology, and this gives us a much more rapid result than culture. Culture is required to determine which species of dermatophyte fungus is infecting the human. And that's important because different species of fungi might have been acquired from different sources of infection. So, for example, some dermatophyte fungi spread only from humans to humans. Some species will come from, for example, hedgehogs, cattle, cats and dogs. So by culturing the scale, we can identify which fungus is infecting the human, and that can tell us from whence it has come. So culture is really important for epidemiological reasons. So how do we take specimens for mycology? Well, here you can see a specimen being taken. So there's a clean blade. It doesn't need to be a scalpel blade, but they often are convenient. So one needs a clean blade, and the surface of the lesion is gently scraped, and this will produce scale. And the scale can then be made to fall onto the paper. That can then be folded up and sent to the laboratory. Ideally, we use black paper. It just makes the scale more easily visible to the laboratory staff. But if you haven't got black paper, it's more important to stick it on a white paper than not to take your specimens at all. In the laboratory, the scale is divided. Some is put up for culture, some is put up for what's called direct mycology. So the scale is put onto a glass slide. We then put a cover slip on top and then apply 20% potassium hydroxide, which spreads underneath the cover slip. We warm the area and wait, and then we can examine under the microscope. So this can be done either in clinic or in the laboratory. And we may be rewarded by seeing the hyphae of the dermatophyte fungus on the potassium hydroxide preparation. So that will tell us that this is definitely a fungus infection. It of course won't tell us which species it is. For that we'll need to do culture. And this is a Saboreau's culture plate. Scale was applied to this 2 weeks ago, and here you can see the colonies of Trichophyton rubrum. So the appearance of the colonies and the effect that the colonies have on the culture medium and microscopy of the colonies that are grown will allow us to identify which species of fungus it is and therefore where it's come from. So what do fungal infections of the skin look like? So very often fungal infections of the skin are called tinea, and this is Tinea corporis, a fungal infection sometimes called ringworm of the body. Typically they produce slowly spreading ring-like lesions or annular lesions, but they've usually got peripheral scaling. So one of the hallmarks of a dermatophyte infection is superficial scaling, and they tend to spread not as quickly as impetigo, more slowly, maybe over the course of a week or so, to produce lesions of this extent. Here's a close-up of a lesion of Tinea corporis. Note that there's central clearing, a red ring, but surmounted on this is superficial scaling, and you could accentuate this by scraping it with a scalpel blade. Here you can see a lesion of Tinea corporis on the neck. They may be annular, they may be arcuate or horseshoe shaped as here, but note there's peripheral erythema and there's peripheral scale. Here you can see a lady who's got more extensive Tinea corporis. Sometimes the source of the infection is obvious. So this lady acquired Tinea corporis from an infected kitten, and it's taken about 4 to 6 weeks to get to this extent. And here are the affected lesions on the kitten. You can see these grey, scaly, bald areas due to a fungus infection on the kitten, which is then spread to the owner. Here's another example of dermatophyte infection. This is Tinea cruris, affecting the groin, sometimes called jock rot. And the scale is often accentuated towards the periphery on the thigh, and it may be spared at the apex of the flexure. Here's a very common pattern of dermatophyte infection. This is interdigital Tinea pedis, or athlete's foot. And the scale and maceration, particularly on the fourth web space. You can also see that there's also a fungal infection of the adjacent nail. And as we mentioned in the previous lecture, this can sometimes be an important portal of entry for cellulitis. Here's another type of Tinea pedis. This is called moccasin type Tinea pedis, and it tends to produce superficial scaling over the sole, but it often then extends up and is obviously marginated on the instep. Again, you can see there's an associated fungal nail dystrophy. And this pattern often affects both soles but one hand. So here you can see the fungal infection of the palm. so that the right palm is the affected palm. You can see that there's superficial scaling and accentuation of the skin creases. The left palm is unaffected. So remember, the maxim unilateral hand eczema is fungus till proved otherwise. Because this obviously is a mimic of hand eczema. Unilateral hand eczema, fungus till proved otherwise. Fungi commonly infect the nail plates, and the toe nail plates are most commonly affected. So this is called lateral subungual onychomycosis. So onychomycosis is the name that we use for fungal infections of the nails. It produces a yellow, opaque nail plate. There's often separation of the nail plate from the nail bed below, and there's scale and debris underneath. The dystrophy tends to start at the free edge of the nail, and then it works proximally. So onychomycosis, Tinea unguium, fungal infection of the nail plate. Another pattern of onychomycosis that we see is so-called superficial white onychomycosis. So this produces this white, opaque changes to the nail plate, and these are rather powdery when they're scraped. Less common than toenail fungus is fingernail fungus, onychomycosis of the fingernails. Here you can see the separation of the nail plate from the nail bed. Again, it starts at the free edge and works proximally. Multiple nails may be affected. The nail plate is crumbling, and there's debris underneath the free edge of the nail. One problem that we commonly see is the inappropriate use of topical steroids on fungal infections. This tends to make the fungus infection spread more readily. It's sometimes termed Tinea incognito. So here you can see extensive Tinea cruris, and it's been spread by the inappropriate use of topical steroids on the fungus. This man had a small fungus infection on his neck, inappropriately treated by the use of a topical steroid, and it's made the fungus spread widely over his face, down onto his chest. You can see that obvious peripheral scaly edge, which is typical of a fungus infection. Another example of Tinea incognito, or a fungus infection that's been modified by the use of topical steroids. Not only does the topical steroid make the fungus spread, it can also push it deeper into the skin, and it can produce a pustular eruption. So this is somebody who's had a steroid applied to fungus on the back of his hand, and it's produced this localized pustular eruption, Tinea incognito. Dermatophyte fungi can affect the scalp and hair, and we call this Tinea capitis. There are two principal patterns. We can see infection of the outside of the hair shaft. This is called ectothrix infection. And this produces a scaly, bald area because the hairs break off after about 1 or 2 millimeters of growth. So you often get left behind broken, short, rather lustulous hairs. Endothrix infection is infection by dermatophyte of the shaft lumen. So the hairs tend to break just as they exit the scalp of the ostium of the hair follicle. And this produces a pattern that's called black dot Tinea capitis. Scalp ringworm tends to occur more commonly in children. It produces scaly, bald areas. Here's an example of ectothrix infection. There are short, broken, lustulous hairs. And with some species of fungus, the hairs fluoresce green. So in the upper area we can see a scaly bald area. On the lower panel, when examined under fluorescent Wood's light, you can see a green-blue fluorescence. And this confirms the presence usually of Microsporum canis or Microsporum capitis, which is caused by either cat or dog ringworm. And here's an example of endothrix infection. Slightly scaly, bald areas, and if you examine this carefully, you can see that there are little black dots where the hairs have snapped just as they pass through the opening of the scalp, the openings of the hair follicles. Sometimes you'll get one or two little pustules as well. Tinea capitis, caused by some animal ringworm, can produce an acute inflammatory reaction which is called a cheiron. And here you can see there's inflammation, swelling, hair loss, and this is called a cheiron. It's usually due to either cattle ringworm or ringworm acquired from cats and dogs. This little lad is a farmer's son. He acquired Tinea capitis from cattle, and he's got Tinea verrucosum producing this scaly, oozy area. And once this was lifted off, there was a large area of hair loss. So we've seen that a variety of clinical pictures caused by dermatophyte infection. How do we treat them? Well, with inextensive infection of the skin, we can use either a topical azole, such as clotrimazole or miconazole, or an allylamine, and the agent used there is called terbinafine. So these are usually used as either creams, ointments, shampoos, or foams, and they're for inextensive disease. With more extensive Tinea corporis, we may use an oral allylamine, so that'll be oral terbinafine, or an oral azole, such as itraconazole. Scalp ringworm, nail ringworm, and ringworm of the palms and moccasin type Tinea pedis usually requires an oral allylamine. Scalp ringworm particularly, you cannot rely on topical treatment only. For scalp ringworm, we usually need 4 weeks of an oral agent. For toenail infections, we would need at least 3 months of continuous therapy, usually with terbinafine. Fingernails may respond only to 6 weeks treatment. One of the problems in recent years has been the development of antifungal resistance, and this probably started in Bangladesh and India and is slowly spreading worldwide. So increasingly, it's important that we take mycology and also do sensitivity testing to make certain that we're then choosing the correct oral antifungal agent. Candida is one of the more common yeasts to affect the skin. It will produce vulvovaginal changes, thrush, but it can affect the flexural areas, particularly the groins, the perianal area, and the axillae. And it's relatively common to complicate nappy eruptions in children. Candidiasis can be quite prolific and extensive in diabetics. So this image here is of a lady who presented with this eruption on her buttocks. You can see there are lots of little satellite pustules. Scrapings demonstrate the presence of yeasts. Culture identified Candida, and the reason that this is so extensive is that this was a first presentation of diabetes mellitus. So remember, extensive Candida exclude diabetes. Candida can infect the nail unit, and this tends to occur in people who've got wet occupations, such as people who might be working in fish shops or have got cleaning jobs and their hands are constantly wet and dry. What happens is that this wetting and drying allows the cuticle to separate from the nail plate, and then there's the development of a potential space on the proximal nail fold, and water can collect in that area, and this allows then the growth of Candida. What happens then is that the nail plate will become secondarily infected and becomes rippled, starting at the proximal nail fold and then slowly spreading out to affect the rest of the nail plate distally. So this is called a chronic candidal paronychia. It produces bolstering and swelling of the proximal nail fold, and because the nail matrix is below here from where the nail plate grows, it produces bolstering, then a secondary dystrophic nail plate. Candidal infections can be treated by a topical azole, such as miconazole. It's important not to use terbinafine, as this is very active against dermatophytes, but not against Candida yeasts. Extensive infections and infections of the nail fold producing paronychia usually need an oral azole, such as itraconazole. Again, terbinafine has no action. The other important thing about a chronic candidal paronychia, it's important to try and keep the nail fold as dry as possible. Otherwise, it just allows recolonization of the proximal nail fold with Candida, and the problem is ongoing. Finally, a common and important superficial yeast infection can occur due to an organism called Malassezia furfur, and this produces a condition called Pityriasis versicolor. And here you can see this man's got these superficial brown, browny, scaly lesions over his chest. And this is what happens when the disease is active. It produces these brown, scaly patches. Here can you see the eruption in close-up. And if you gently scrape these, you'll produce this superficial scaling. If you then do direct mycology on this, you'll see the pseudohyphae and spores typical of Pityriasis versicolor, and the appearance is said to look a bit like spaghetti and meatballs. Once the infection has been present for a period of time, it will produce and appear as areas of depigmentation. And the reason for this is that the causative yeast produces an acid called azelaic acid, and this is toxic to the melanocytes. So what happens is that you get areas of depigmentation which contrast with the normal tanned skin. So this hypopigmentation tends to be more obvious in the summer months when people have got a suntan, the affected areas appearing hypopigmented, the normal skin is tanned and darker. And that's why this is called Pityriasis versicolor, different colours, because when it's active, the lesions are brown and scaly. And in the summer months, perhaps when the disease is inactive, the effect of the azelaic acid on the melanocytes produces areas of depigmentation, hence the term versicolor, different colours. Pityriasis versicolor can be treated either topically or orally. Small areas, one can use an azole cream such as clotrimazole or miconazole twice daily for 2 weeks. Larger areas, it's often more convenient to use ketoconazole in a shampoo base. This is applied to the wetted skin, left on for 10 minutes, and then rinsed off, repeated daily for 5 days. An alternative is to use selenium sulfide shampoo. Again, apply to wetted skin, leave for 10 minutes, do this daily for a week, then weekly for a month. Sometimes it's more convenient to use an oral agent. Itraconazole can be used 200 milligrams daily for 7 days, although recent evidence suggests that much shorter courses are just as appropriate. terbinafine should be avoided because it has no action against the causative yeast. It's important to inform patients that the hypopigmentation may take up to 6 months to recover, even with effective treatment.